again for our last lecture. Yeehaw, the last lecture to go through. It's just two things, but these two things they are just as in depth as all the other things that we be talking about. Okay, so let's just do a brief go over of the stuff we learned last time. Okay, stuff we learned last time, we were talking about MG, myasthenia gravis. Remember the gravity. This is an issue, okay, that occurs at the neuromuscular junction, kind of. Yeah, that is exactly what happens. Well, not really. More like the synaptic gap of the neuron, okay? And it is where for some reason, because of some autoimmune issue, could because of Epstein-Barr, it could just be because you have a genetic predisposition. Your immune system looks at the receptors for acetylcholine in the synaptic gap and says, kill those guys, resulting in a lack of of the acetylcholine receptors at the synaptic gap, meaning that our body's ability to use acetylcholine to move is essentially like made harder. We need more acetylcholine to do the things that we need to do to reach above that action potential and make movements, resulting in a lot of fatigue, muscle weakness, potentially muscle spasms, wherein myasthenia gravis, these people, they need medication that has more essentially like acetylcholine, but it essentially gets rid of some of the acetylcholine, acetylcholinesterase, I think is what it's called, the protein that, or the enzyme that gets rid of acetylcholine. If they can get rid of a little bit of that, right, your body can use the acetylcholine it has more effectively, right? So for people with myasthenia gravis, making sure they get their medication on time, right, and making sure to cluster activities within the period that they are at their most able to use their acetylcholine is super necessary, okay? Not only that, but there's a chance that somebody with MG can go into two types of homeostatic imbalances, okay? Related to their disease or the medication that they're taking, okay? So in myasthenia gravis, when you're taking this medication, right, which I believe is prostigmin, Prostigmin is the one I remember, but I remember there's more than it's called really the same thing. Pyridostigmine. Yep, pyridostigmine. Anyway, when you're taking those, they are inhibiting your body's ability to get rid of acetylcholine. So there's a chance you could have a myasthenic crisis. Okay? And in that myasthenic crisis, or actually, let's call it the one where you can't get rid of let's start with myasthenic crisis, okay? In a myasthenic crisis, kind of delete what I was just saying. In a myasthenic crisis, a person has not gotten their medication. They do not have the acetylcholine necessary to be doing things very well. So they essentially have a, the way of discussing it is you can't see and you can't pee, you can't spit, and you can't shit. The point of that being acetylcholine is responsible for the movement that happens in your body, be that of smooth muscle, or at least it helps, right? The smooth muscle fibers, also your skeletal muscles, everything, right? It also helps to engage your body's ability to produce saliva. So if you've got, hold on. Yeah, in a myasthenic crisis, you don't have acetylcholine because it's not being used. You can't use it essentially, or there's not enough for you to be able to actually use effectively. So the fatigue essentially takes over to an extreme. This can get bad really quickly, especially if the person's diaphragm stops working. That's a myasthenic crisis. There's a cholinergic crisis, which is where it's essentially the opposite problem, where acetylcholine, because of the medication this person may have been taking, there's too much of it. And those things we talked about with myasthenia gravis, well, now you're secreting a lot um, of saliva. The I think the acronym for this is BB sludge, bronchospasms, bradycardia, like salivation, lacrimization, tear production. Okay, because that's part of what acetylcholine does. Urination, um, D, diarrhea. Yeah, D for diarrhea, baby. And then DE. What the crap? I think it's excess something. um, emesis. Emesis. I forgot G. GI cramps. Oh my word! I spelled sludge freaking wrong. That's so embarrassing. Hey, you know, that's so embarrassing. Yeah, that's so embarrassing. Anyway, BB sludge. Okay. And that can also be life threatening because if you've got that GI irritation, you're diarrheaing, you're vomiting, you are and you're bradycardic, you are I mean, there's a lot of things that can go wrong, especially if you tip into the realm of hypotension. If you lose too many fluids with a cholinergic crisis, we're worrying about fluid volume deficit. And if you're already bradycardic, because that skeletal muscle's ability to, contract well is hindered. Not only that, you're dealing with bronchospasms, like you would get if you were getting some sort of asthma attack. Although it's not as bad, you are still worrying about breathing. I'm worrying about breathing, and let's be real, okay? That's airway. I mean, yeah, just because it's not high enough, it's still the airway to your lungs. And if those are spasming, your ability to get air into your lungs is way decreased. So, yeah, either of those crises are really bad, and you should know what the signs and symptoms are. You should tell the person who may be at risk for them what the signs and symptoms are, how to prevent it, right? Taking your medication on time with the right dose. Don't increase it for fun, okay? Because otherwise you will be you won't be shitting or giggling, okay? That's so funny. And then that's MG. we will do a long review because it's good for me so that I can remember as well. Rheumatoid arthritis is also what we talked about that. It is where there's been some sort of rheumatic disease that's in the way it usually goes is these rheumatic diseases, they really love to chill out in your joints. Now, with rheumatoid arthritis, your body, once again, it's an autoimmune disease where your body looks at all those guys in the joints and says, kill them. So it goes into your joints, inflames them, eats them away, really messes up your hands and in your knees and your joints. Yeah, mostly your knees, your wrists, fingers, ankle kind of things. And it's pretty painful. It's not fun for people. And the way that they kind of figure out that there's like a rheumatoid problem is that they can do some like tests to see if not only you have rheumatic factor, but if you have any sort of inflammatory markers like ECF, and then ANA, which is auto ANA antibodies. Oh, auto something antibodies. That's so embarrassing. I didn't write it down. Kind of stupid of me. How about we look it up, huh? Blood. Anti-nuclear antibody test. There we go. So, yeah. Looking for those tests. One other thing to remember about RA that kind of differentiates it is that the pain for RA is going to be worse in the morning. A lot of other neuromuscular diseases, for example, we're going to talk about fibromyalgia. We're going to talk about, that's the one that comes next. The pain for rheumatoid arthritis is going to be worse in the morning. Fibromyalgia, which we'll talk about next, the pain is worse in the evening. And I want to double freaking check that because if I'm wrong, I'm going to be so mad at myself. La 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 the crap? Where the freak is it? Where the freak is that? I guess I didn't write it down. I guess I just talked about it like an idiot. Idiot. Hold on. I just want to make sure I'm not crazy. Just want to make sure I'm not crazy. La la la. Yep, I'm not crazy. So I just didn't trust myself, and I should have trusted myself. I should have trusted myself. All right. Anyway, next. That's a big thing with RA. I mean, with all of these, by the way, MG is the only one here that has like a special, like its own special thing with pyridostigmine. For RA, the person can receive, I believe hydrochloroquine. Yep, but they'll stop hydroxy. Or sorry, I really want to say hydroxy, but that's not part of it. With hydrochloroquine, there's a risk for retinal like deterioration that can happen. So if your patient ever starts like seeing black spots or whatever, like that's something that you should definitely report to the doctor, because the doctor will very likely stop the medication, just because you don't want to continue to rip away that retina. Like that could lead to bright blindness. Not good. But with all of these, like steroids, because these are inflammatory. MG is not as much of an inflammatory thing, I would say, but it's got its own deal. The problem with MG is mostly the fact that we don't have that neurotransmitter, right? Now, they might do some immunosuppressants as well. So, I mean, in that case, you could maybe consider, but the problem here isn't inflammation, right? With myasthenia gravis, you don't have an inflammation problem, so you wouldn't necessarily need steroids. With RA, you would want some steroids. You might also want some steroids for fibromyalgia, but immunomodulators are going to likely be used for at least MG and RA. With fibromyalgia, they want to reduce that inflammation for sure. But for fibromyalgia, the big thing with that is that they call it it's all in your head kind of. And I don't mean that in like a bad way. I mean that in literally, fibromyalgia is a problem with how your brain processes negative sensations. Fibromyalgia can be set on by a lot of different things. Could be Epstein-Barr virus, could just be like a really stressful event, could be a genetic predisposition, but or it could be chronic pain, any sort of chronic thing if you've had chronic pain in the past. But like, it is an issue where your brain, like I mean, there's a lot of different pain theories, and we kind of went over them briefly, but it's this issue where your brain, your central nervous system, anytime there's a negative stimulus, at least in like four main quadrants, your brain just goes, pain time, sends down a thing to say that your body's in pain. You're not in pain necessarily. There's very little, if any, inflammation that kind of happens with fibromyalgia, right? It's not a autoimmune disease. It is literally signals in your brain telling you that you're hurting. And why would that happen? They still are trying to figure it out. Some things to remember about fibromyalgia, though, that's important to know, is that you cannot treat it with opioids. And I wondered why. I was like, why couldn't you treat it with opioids? Like, that doesn't make any sense. But the thing with that is that opioids, they work, like, I looked it up, and they work, like, directly at the synapse, kind of, right? They're trying to, like, move, essentially, like, the pain. They're specific receptors for opioids. So by giving opioids, right, those receptors in your brain, yeah, they'll be stimulated, but it doesn't change the fact that the inflammatory mechanism, that pain stimulus is still shooting off. So somebody who has fibromyalgia and who gets morphine, right, maybe their pain goes away for a little bit, but ultimately they just become more addicted to those opioids because those receptors are being stimulated without actually really and truly addressing the main issue, which is your brain is telling your body to freak out. So they can give steroids for this one because there is some inflammation associated with it. It's mostly like your body kind of freaking out, but it's less about that swelling, right? The big thing with treatment for fibromyalgia is NSAIDs, okay? And the reason that NSAIDs are really important is that your brain, like, you don't have pain in your head, okay? It's like a peripheral thing. All right. Tylenol's not going to work because Tylenol is like sitting there trying to decrease the inflammation in your head, right? It essentially kind of numbs you to the pain that you're feeling. Well, that's not happening here. You have a stimulus that's shooting out to your peripherals, your peripheral nervous system saying that something hurts, right? Because your body is ready to become inflamed at any given moment, essentially. Not in the same way that we'll talk about in lupus, but it's more of a your body would love to be in pain. It's terrible. So NSAIDs, not opioids. Opioids are kind of a no-no when it comes to fibromyalgia because it can make the pain worse and not really better. And overall, the main thing with fibromyalgia is you kind of just have to deal with it. Like, you can control pain as much as possible, but overall, it's like try and keep the stress away. Try and manage those negative stimuli because those are the things that are going to be like your brain's just going to go, oh, okay, something bad. Send the pain. Not great. So yeah, antidepressants are big for this one. Anti-seizure medications because just negative stimulus like gabapentin can help with like the nerve pain because it does happen at the nerve juncture. So just things to think about. Any inflammatory mechanisms here. Yeah. It's just like here, widespread neuroinflammation. So it's not like tissues being inflamed like we'll talk about in systemic lupus, but it is like your nerves. Your nerves are the ones who are like, go crazy, go stupid. All right? And that results in nerve pain. It is nerve pain. It's not tissue pain, it's nerve pain. And so in different clusters, specifically 4 clusters for at least 3 months, where that could be your right leg, right arm, back, and like left shoulder, those could all be locations where you just get this strange and really awful pain when you're like, I don't know why this is happening. So fibromyalgia. Moving on, we got 2 more we got to learn, and that is systemic lupus erythematosus. Oh my word. And ALS. Which, do I remember exactly what that is? We'll remember after this. LOL. Okay, systemic lupus erythematosus. So, what is that? What's lupus? So, SLE is... So we talked about fibromyalgia being like a systemic nerve inflammation thing, okay? The nerves freak out. The nerves are kind of going crazy, going stupid, resulting, in nerve pain. Well, nerve pain is unfortunate, okay? But it doesn't really show up as your typical inflammation if you were to do a panel looking for those inflammatory mechanisms. Steroids will work because they help to reduce inflammation overall in your entire system. However, the inflammation in the specifically of like fibromyalgia is nerve focused. Okay, so the tissues don't really feel much other than ow, everything hurts all the time. Okay. Systemic lupus is different, okay? This is an autoimmune systemic inflammatory tissue disease for your connective tissue. Hey guys, where do we have connective tissue? Oh, everywhere. We have connective tissue all over the freaking place. All the cavities in our body are made, like there's connective tissue connecting them to other things. We have connective tissue all over our heart, in our heart, surrounding our freaking like GI system. It's not like we have so much connective tissue all over the place. And in SLE, that tissue becomes inflamed, okay? And it's really unfortunate because it's an autoimmune disease. For some reason, our bodies have decided that connective tissue is the enemy. They're really quick to do that. Well, and in contrary to like in rheumatic diseases where there's some sort of like disease process, some sort of antigen that's like hanging out in those tissues where it's more of a focused approach. In systemic lupus, you have connective tissue everywhere. Your antibodies could just say, yeah, I think we're gonna destroy the. I think we're gonna start getting really angry at this joint right up here. Oh goodness, it's really not fun. Okay. In fact, you have connective tissue in your blood vessels, okay? Immune complexes attack the blood vessel flow, and it's a very painful disease. But the reason that this is going to kill you, and fibromyalgia really won't necessarily, is that inflammation to these organs, when your organs get inflamed, they are kind of programmed to do certain things. Inflammation makes it harder to move things, and inflammation usually makes things want to get smaller. Okay, in systemic lupus, if left uncontrolled, unmitigated, it essentially makes your blood vessels so tight, so inflamed that blood can't really get through them, okay? In almost a hypotensive kind of way. We don't have enough blood volume getting to our organs, all right? And so the number one cause of death for people who have lupus is that their kidneys fail because they're not being perfused, because our blood vessels have become so inflamed due to the fact that the connective tissue that's holding them in place is inflamed, that you don't have blood flow. So, and here they have systemic lupus, and we talked about how it's different than rheumatoid arthritis, okay? But it's often misdiagnosed as rheumatoid arthritis, right? Because rheumatoid arthritis is a connective tissue problem. It happens in the joints. So in systemic lupus, you've got these big joints in your hands and your knees, and they hurt. They hurt because they're inflamed, but it's not because of any sort of virus or any sort of bacteria. It's simply because your body just decided one day that it just hated your connective tissue and wants to get rid of it. Pretty awkward. There's a couple other types of lupus. I won't be tested on them, but I think it's important to kind of think about what they are. There's discoid lupus, which is specific to the skin, because your skin has a lot of connective tissue. And now I'm about to sneeze. Once you say that, of course, the sneeze goes away. It's got like performance anxiety. But discoid happens in the skin, and then there's also drug-induced systemic lupus. But this is temporary. It happens in response to a drug that your body just does not like. And yeah. But that's a tale for another day. Overall, what you have to remember is systemic lupus is an autoimmune connective tissue inflammatory, chronic inflammatory disease, okay? It's most common in women and people of color. And maybe after menopause, it'll go down. Yay! Woohoo! Another win for menopause. I'm sorry. I was like, well, we're replacing your systemic lupus with osteoporosis. Oh, thank you. Anyway. So this is just like a little case study, and this is how they kind of went over signs and symptoms and stuff. And so I think that these are things to just think about. So, yeah, they have here 8-week history of joint pain and swelling in the hands, right? Remember, this is a connective tissue inflammatory disease, okay? There are markers of inflammation that you have to just kind of know. Swelling, redness, pain. Those are big ones. And heat is also another one, okay? Swelling, redness, pain, heat. If your body's inflamed, you're going to get that, okay? And so in this situation, this lady is coming in. She is going to have those symptoms of her joints being inflamed, okay? If she's got lupus. Now, they look at this. You read that, and you see that in your hands, knees, and ankles. Those are exactly the places where in RA, you're going to have the exact same symptoms. So that's why it's commonly misdiagnosed, because you have the same symptoms, except for a little bit more. So we'll talk about a little bit more. You also have pain here. They've got fever, all right? Myalgias, which sounds like something that I should know about. Muscle pain. Hey, that makes sense. Pleuritic chest pain. Ooh, now here's something that can help to differentiate, right? remember that in an RA, it's generally it doesn't usually go there, okay? Because it's usually in a couple places symmetrically, hands, like knees, ankles, wrists, in and because it is where those bacteria decided to hang out. Remember, we talked about how your cavities are often kind of helped to stay where they are with connective tissue. Well, hey, chest cavity, connective tissue, you're going to have pain, all right? Near that chest, it's going to be in the near the cavity, right? It's not going to be chest pain located like in your heart region, right? It's going to be kind of maybe around, besides, underneath when you breathe, when you do all the, when you start moving your lungs, you're going to be like, oh, that does not feel good. Weight loss, and that weight loss has to do with just some of it is muscle wasting, kind of. Others of it is just due to the fact that pain makes it hard to live life. I'm going to double check that because I think I looked it up yesterday. Why weight loss in SLE? Reduce appetite, digestive issues, certain medications to fight the disease. Yeah, so living life is hard, like I said. Not only that, and one thing I should have thought about is that guess what else is made up of connective tissue? Your GI system. There's a lot of connective tissue there. I mean, it's not made up of it. There's a lot of smooth muscle, but that's not related. There's connective tissue all surrounding that. Like the mesentery, right? That's a whole thing of connective tissue that's like right there holding the small intestine to the wall. That's going to get inflamed potentially. So you're going to not want to eat because it just, like, your stomach just hurts. Like, why would you want to eat when you're just getting stomach aches in that area? And it doesn't feel good to eat. You might even have GI irritation and you don't want to keep anything down. And then a facial rash that worsened with sun exposure. Now, this is a big one. The reason why this is like a historical cute little fact. The reason why they called it lupus is because apparently some bozo looked at the face rash, which is this. They looked at the face rash and they were like, that looks like dog. Huh? What? Guys, who let this guy? That's so dumb. What? Anyway, apparently he was thinking werewolf because it was like a transformation kind of a thing. Listen, I don't make the rules, okay? I'm just providing historical basis, okay? I'm just here for knowledge. I can't control the fact that it's kind of stupid. Anyway. So that face rash, the butterfly rash, that makes sense. Hey, butterfly rash. But no. Dog. That looks like a wolf. Hey, really? Hey, have you been outside before? Maybe you should go to the zoo. Hey, let's take a field trip. So anyway, she had been seen initially at a local clinic and treated for cellulitis with that. Okay, because it's often misdiagnosed, whatever. Cephalexin, I think that's an antibiotic. Yes, it is. Well, an antibiotic's not going to help here because there ain't no bugs in this lady. Seen another ED, had a really high temperature, protein in her urine, and anemia, and was told it was viral syndrome. Womp womp for her, I would say. So these are important labs to think about, and we're going to talk about more labs here in a second. But that fever, inflammation, right? Inflammation, one of the things is heat. Okay, so proteinuria is really interesting. And I'm going to hesitate a guess, and then we'll pop in with asking Google to, like, verify. But remember what we were talking about with, lupus nephro-something? Lupus nephritis. Duh. Where there's problems with blood flow to your kidneys. All throughout your body, like, there's some damage. And I don't know, maybe that has something to do with it. Why proteinuria in SLE? Key indicator. Okay. kidneys are inflamed and damaged. Well, there you go. And because those kidneys are being inflamed and damaged, the glomeruli ability to like keep out the big nasty proteins gets diminished because the glomeruli are fighting for their freaking life. Don't hurt me, please. And the proteins are like, let me in. And then you pee out your protein. Sucks. And anemia. Oh, why is that? Well, your protein. Okay, let's talk about what makes blood in your body. Okay. So if your kidneys are being damaged, it makes sense that they would like have problems sending the message out to your bones to make more like with red blood cells with erythropoietin. That would make sense to me. Kidney problems and the body's autoimmune response, because I guess it just is like kill everything. So, hey, we guessed that. I'm proud of that, babe. Can cause a body's own immune system to mistakenly attack and destroy its own red blood cells. And see, now that's so embarrassing. That's so embarrassing. Hey, part of our entire immune system is to be able to recognize friend from foe. And in SLE, they are literally cooked. They can't. They're at that. If you're destroying your own blood cells, I fear there's what's next. Oh, the kidneys. Oh, kidney failure. Okay, yeah, we got him. We got him, team. Oh my. Okay. Anyway, one thing about lupus, if somebody in your family has an autoimmune disease, there's a correlation, not a causation. They don't have like as much proof as they would like. That's what that means. But if anyone in your family has an autoimmune disorder, you have a chance of getting lupus. Another thing, stress can trigger flare-ups of like lupus and any autoimmune issue. If you've got MG, RA, and even like fibromyalgia for sure, which it's different. Let's leave fibromyalgia out for a second. Any sort of autoimmune problem will be increased by stress, because stress will automatically cause your body to experience a little bit of inflammation, because you're like, you feel as if you're in danger, like your systemic or your oh my goodness, sympathetic nervous system is stimulated. Even if it's just like a little bit, it's increasing your body's workload, and it's telling your body like, prepare to run, fight, win. And unfortunately, long term, that can cause inflammation, just because your body is freaking out. Your immune system, she is ready to kill at any given moment. If your immune system decided right now it was done with you, you would die. You would absolutely die. It could kill you in so many ways, slow or quick. It is so unfortunate, and honestly, I feel like I'm looking back at all the things we've learned about in this semester, and I'm like, the immune system being stupid is like a really solid good chunk of why people are gonna die. It's a good chunk of reasons. It's a good chunk, and it's a lot of these chronic diseases because your immune system is just like, how about we kill it? And your immune system, it really does mean well. It's just, it can't help its nature. Okay, this is one situation where I'm like, no, this is the nature of the immune system. The immune system wasn't risen this way. Risen this way. They weren't. This is not any sort of thing other than it just being this way. She was born this way. Okay, you can't hate her for who she is. I mean, I guess you can. I would if I had lupus. Oh, I'd be like, get my immune system out of here. And maybe you can with some immunosuppressants, but we'll get to that. So here are more labs. Now, these are like made up, okay? But the point of them is important, okay? So for this person, remember, let's just go through everything, all right? So she's got a high temp, all right? It's kind of high. Her blood pressure is a little bit high, which could just be due to pain, right? That's one reason why your blood pressure might increase. Painless ulceration on the palate. That's another big sign that she might have lupus. Because skin has a lot of connective tissue between all the layers and everything. So, mucosal tissue. She also has that butterfly rash. So things like that. Molar rashes. same deal right there. Diffuse lymphadenopathy, okay? She's got swollen lymph nodes, all right? Are they connective? Lymph nodes. Yes, lymph nodes are surrounded by and contain connective tissues, including a capsule of dense connective tissue and trabeculae. Hey guys, I should get an award for pronouncing that correctly. I think I did, at least. That extend inward, providing structural support. Yep. LOL. Well. Really awkward. Bummer. But anyway. And it's diffuse because, hey, everywhere your body is fighting for its life. And synovitis, which is inflammation of the synovial joints. Which joints are synovial joints? That's a great question. I think it's like your hands and feet and knees and stuff. It's where they have synovial fluid, okay? Freely movable joints that allow for a wide range of motion between bones. Most common, anyway, size and shape, blah, 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 blah. And of these freaking joints, I don't know what those are. But look at those. Look at those swollen fingies. Swollen phalanges, huh? Anyway, so there's the butterfly / malar rash, pallor ulceration. I love how I said molar rash and it was literally malar rash the whole time. I'm really not that special. Okay, back to labs. So here's our patient. Low white count. Why is that? Because this isn't necessarily a bacterial thing. Now, would the white count be high initially? Hey, maybe. But at the end of the day, your body has a harder time producing blood products. It's having a harder time, it's always inflamed. Your white blood cells are always working. Essentially, they're being overworked. So long term, right? Maybe when you have your first time ever getting your systemic lupus SLE, your first time getting it, you might be might have a little bit of a high white blood cell count, but eventually your body just can't keep up with the demand for the white blood cells, so your white blood cell count will be low. Hemoglobin will be low. Your abilities to create red blood cells is lower because your bones are inflamed, your kidneys are inflamed, and your body is working really hard to try and keep it all together. Platelets are going to be low. Same reasons. Blood product production is down. Creatinine here is okay, right? And remember, creatinine is a measure, and I want to check that, but measure of hold on. It's a waste product created by muscle metabolism, filtered out of blood by the kidneys. And if that's high, there's been a lot of damage in the body, and the kidneys can't really, they're trying their hardest to get it out. That's putting a lot of strain on kidneys. And I want to look back here because I have a great little picture of all the stuff involved in what creatinine is all about, okay? Creatinine. It's not usually reabsorbed. If the glomerular filtration rate is low, creatinine only goes up if it isn't being filtered well, okay? So if we've got a low glomerular filtration rate, okay, which would get lower if our kidneys are getting wrecked and our creatinine goes up, that's because we are not actually able to get rid of it well. It's not being filtered well. So it's causing a bit more problems, okay? And creatinine can also be secreted in the nephron, if it's being injured, right? Which will, of course, increase more creatinine. So And that creatinine, that's in the body. And if serum creatinine is going up, that means that the kidneys aren't being able to get rid of it, basically. And that's bad, because that means the kidneys are failing. They're failing. Albumin. Albumin will be low. Albumin is a blood product and a product of our proteins working hard to keep our blood in our intravascular space. If it is low, that sucks. That's really sad. Their urinalysis will be positive for protein. Of course, you may even have some red blood cells in there because your kidneys are not working very well. ANA, autonuclear antibody. Here we go, people. Remember that? Autonuclear antibody? Autonuclear antibodies, they're not like specific to any specific disease, but what they are essentially are an antibody in your body against your body that looks at your cells and goes, I think I could defeat that nucleus. Let's kill it. It's autonuclear antibodies. And to have those be high means that your body, this is an autoimmune problem. And then there's another lab that you can use to kind of differentiate what lupus is from anything else, and it is this dsDNA antibodies, which I don't know what DS stands for, so we're going to look it up. dsDNA AB. Anti-double-stranded DNA. It's antibodies that target double-stranded DNA, a type of genetic material. That's really awkward. Not fully understood, but they are thought to play a role in the development of autoimmune diseases. Cool. Cool. And the biggest one here is SLE. Well. So high, and this is a big one. Like if doctors are trying to diagnose this, they'll be like, okay, well, let's see if there's dsDNA antibodies, double-stranded DNA antibodies, and if it's high, there's a chance you got lupus. So they have that. Yep. So SLE, how'd you get it? The big thing with this of like how SLE affects your life, because that's the question, right? Lupus can kill you if it's not like really managed well, because if you just let it kind of go out of control, it can cause damage to your kidneys, which causes kidney failure, which will cause you to die, like an acute kidney injury kind of issue. You will be in trouble. And you can get it from any sort of reason. Could be genetics, could be an external trigger, like some sort of really bad infection. Could be both of those things. The thing is, people who get this, right, they just have to be really careful about keeping their body at a very low inflammation state. If they can do that, which means avoiding inflammatory type foods, doing well for their bodies. I love how I spelled exercise. Don't look at that. I want to spell exercise like that every time I see the word, and I know it's wrong, and I just do it accidentally. One thing, though, that would be included in patient teaching would be that pregnancy, because pregnancy is a very inflamed state. Your body will be inflamed with pregnancy, and so people who have systemic lupus erythematosus, oh my word, Amazon photos, if you don't keep yourself quiet, if I see anything pop up from Amazon photos, I'm going to crash out. Yeah, go away. Yeah, that's what I thought, Amazon photos. Anyway, with that pregnancy, it can cause more flare-ups, which would cause damage to the baby and the mother. It's not great either way. Anyway, so chronic progressive inflammatory connective tissue disorder with remissions and exacerbations, causing blah, blah, blah. We talked about this. Oh, that's crazy. Complexes love kidneys, unfortunately. Yeah, that sucks. And remember, lupus nephritis, most likely cause of death for lupus. So here's our Maller/butterfly rash. You're going to see severe fatigue, severe body pain, achy joints, and potentially confusion. And I wonder why that is. Why confusion in SLE? And that would definitely be during a flare-up. Like, somebody who has SLE isn't just going to be confused all the time. But The confusion or brain fog can stem from inflammation in the brain and nervous system as well as other factors. So it's essentially like it's like delirium kind of almost, where your brain has just had enough, like it just cannot focus anymore. So more lab findings. We talked about the ANA antibodies and the anti-double-stranded DNA antibodies. They have these things called anti-Smith, also known as anti-smooth muscle antibodies. That sucks. That'll affect your freaking blood vessels. That'll affect your GI tract. Ooh. Diagnostic for lupus. CRP, which is an inflammatory marker, as well as ESR. All of those are inflammatory markers. And you'll also see these with other inflammatory diseases like autoimmune inflammatory diseases like rheumatoid arthritis. C3 and C4, those are both complements that are part of the I think that they're part of the inflammation cascade. So I have a little thing here. Proteins that normally work, those are C3 and C4, with the immune system to produce inflammation. During the early part of a flare, spell that wrong, serum components are high. So serum complements, these C3 and C4, serum complements are high. Okay? Now, late in not controlled lupus, serum complements have been used up, so their levels may be low. With treatment, serum complements should go back to normal. We don't want C3 or C4 to be too high or too low. And it's kind of similar to the white blood cells being used up. At first, they might go up because they're like, we need to be used. Eventually, your body just can't keep up with the strain of making them. They're using them faster than they're able to make them, which will lead the levels to be low. It's the same here with C3 and C4. Those serum complement levels will go high up initially, right, if this is your first flare of SLE, but as time goes on, and if you are constantly inflamed and there's not really much that's being done about it, those serum complements will go low, okay? And we don't want them to be low because they're there for a reason. But, yeah, so knowledge about that. And then pancytopenia, because everything is low. Your body is using so much of its resources to try and keep you alive, as well as trying to inflame everything. So all of your blood product levels will be low. Now, yeah, there's that. Having a low white blood cell count is very often. Only about half of patients will present with a low white blood cell count. Anyway, drug-induced, and then the skin, we talked about that. Criteria for systemic lupus erythematosus. Oh my goodness. The malar rash, the discoid rash, that's in the arms, one of these guys. Ooh. Photosensitivity. And I wonder why that is. I think it probably it causes like a little bit of irritation on the skin, which can cause that inflammation. I actually think that's correct. I'm not even going to mess around with that. Oral ulcers on the roof of the mouth, arthritis in two or more joints, serositis, which is in like inflammation of like the serum membrane around like the lungs. That's that pleural pain. Because remember that there's all held out by the connective tissue. Renal symptoms, having that high creatinine, maybe like a low urine output, protein in your urine, and maybe even a higher white blood cell count in your urine. Those are all renal symptoms. Neurologic disorder, that seems like a confusion kind of thing, like long-term memory problems, difficulty concentrating, stuff like that. Brain fog. Hematologic disorder, anemia. That would do it. That'll do it. Positive serum studies. I have no idea what that means. That probably just means that they have all of the markers, like the Smith antibodies and the double-stranded DNA antibodies, and then positive for antinuclear antibodies. For systemic lupus erythematosus, I'm just going to keep on saying SLE. That's so embarrassing. You have to have at least 4 of these signs and symptoms. Any 4 of them to have a positive diagnosis. So here, the inflammation in the pleural cavity can cause a buildup of fluid, so they can have pleural effusions in that pleuritic cavity, where they might want to have a pleurodesis, where somebody sticks a freaking tube in that area and drains the pleural cavity, so your lungs have actual space to do stuff. And they also might get cardiac tamponade, which is the heart version of a pleural effusion. Yeah, the pericardium around the heart gets filled with fluid, causing the heart to not be able to move around effectively, not to be able to beat effectively. Now remember with a cardiac tamponade, okay, your EKG, all of your EKG is going to be smaller. Let's cardiac tamponade EK. What the freak? Well, let's just say ECG since it's there. Look at those little guys. Look at these little freaking dudes. They're so tiny. How cute. Not cute. Not cute. Cardiac tamponades not good. Anyway, so treat symptoms for cardiac tamponade for sure. Getting fluids on, vasopressors. This is like a really big deal. Cardiac tamponade is bad, okay? Really bad. And then here for pleural effusions, we're just going to go over like the things they're going to use. They use tetracycline or talc to irritate this area, right? Which helps to cause scar tissue to form while they're like getting the stuff out. So like with a chest tube. And so with a pleural, like, so hopefully that scar tissue, which is basically just like not pretty connective tissue, forms so that there won't be space for fluid to get there next time. It won't necessarily get rid of the pain, but it can get rid of the fact that there's not enough space for your lungs to fill properly, which is worse, okay? You can manage pain. I mean, but if you're not managing your lupus and it gets out of control, or you exacerbate your lupus symptoms with getting pregnant, which is not great, your kidneys can start to be really, really, really damaged, which will just essentially mean that you have a really bad kidney injury, lots of protein because your glomeruluses are not able to do what they need to do, very concentrated urine, there's no differentiation between which ions are going in and out, and then less urine output overall because it's not your kidneys cannot properly concentrate urine. They can't concentrate it, and in fact, they can't really decide how much to get rid of. So you have decreased urine output and very highly concentrated urine. And the implications for the treatment for this patient are very similar to somebody with like a kidney injury or a kidney disease. A low sodium diet, a low potassium diet. You're going to want to watch this potassium levels for sure. And this person might be on a fluid restriction, but honestly, it just depends on managing that inflammation. And then lupus cerebritis, and that's a condition, I think that's probably what they were talking about when it comes to neurologic disorder, which is where the serous membrane around the brain is inflamed. Because remember the dura mater, arachnoid mater, and pia mater? Really awkward. Those are all made of a bunch of connective tissues, or at least the arachnoid mater definitely is. You can have a change in personality, seizures, decreased level of consciousness, coma, paranoia, just because your brain is inflamed. That might I don't know if that has to do with swelling. In lupus cerebritis, is there brain swelling? In some cases, there can be brain swelling, but I don't think that's typical then. Okay. So medications, NSAIDs to help with inflammation. Opioids will work in this case because it's happening at like the tissue level, so they can give opioids for lupus. Anti-inflammatory steroids like prednisone and methylprednisone. And then you can also give biologic response modifiers, MAB. What else can you give the MABs for? I believe you can give biologic response modifiers to, what was that, like GBS? I want to check that. Lo, 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 lo. I'll just scroll. I'll scroll like an idiot. I'm just gonna scroll like an idiot. Or was it MS? No, those are just immunomodulators. Oh, there was one. I feel like there was one of these other ones that was specifically like the MABs, biologic response modifiers. Um, huh. All right. Well, anyway, biologic response modifiers for lupus: Enbrel, Remicade, Benelsta. These will often be used with like mouse antibodies. So somebody who's taking the like biologic response modifiers may need to take antihistamines and Tylenol so that your body doesn't say, "I'm not a mouse," and freaks out. These people will also be on immunosuppressants to help to decrease that inflammation, specifically like methotrexate. Methotrexate is like a super powerful immunosuppressant. These people, you need to be worrying about them getting like infections a lot. They may also get hydroxychloroquine. There we freaking. I wanted to say that so bad. I wanted to say hydroxychloroquine so bad when we were talking about hydro what the frick, what the heck, where is it? Hydrochloroquine. I wanted to say that so bad, but I didn't. So hydroxychloroquine is anti-malarial. Hydrochloroquine is for multiple sclerosis. No. Myasthenia gravis. Oh, see, this is why this is so confusing. That is why it's so confusing. Anyway, MG, hydrochloroquine. For lupus, hydroxychloroquine or Plaquenil, which is an anti-malarial thing, which helps if retinal damage is detected, just like in hydrochloroquine. If there's any sort of retinal damage, no more hydroxychloroquine for you. And I want to check that that's the case for hydrochloroquine. That's hydroxychloroquine. But what about hydro? But that's for hydro. What the crap? Ugh. They really want to say DMARDs that's hydroxy. What the crap? Is there such a thing as hydroxy? Wait. There's not. Is there a thing? Did they make a mistake on this? Hold on. Hydrochloroquine it was for MG. So they are silly. What the crap? Anyway, whatever. Can cause bone marrow suppression and retinopathy. Eye exam every 6 months for hydroxychloroquine. Oh my word. And then, of course, this anti-neoplastic deal, cyclophosphamide. So anyway, skin protection, because remember, going outside can increase that inflammation in the skin. Monitor for fever, because subtle temperature changes are going to be more likely to indicate infection if they're on all these immunosuppressants. Fatigue. Pregnancy is not recommended. Getting counseling because lupus is rough. And of course, if they're on that antimalarial hydroxychloroquine, they need to be getting an eye exam every 6 months to make sure their retina isn't getting demolished. And of course, avoid heat and stress that can cause those flare-ups. So like extreme heat, like don't get into a hot tub that is like really, really hot, of course. Okay. ALS, amyotrophic lateral sclerosis. This is our last one, also known as Lou Gehrig's disease. Let's talk about the pathophysiology of ALS. So in ALS, you know what? I don't know if I wasn't paying attention. ALS patho. The exact cause of ALS is unknown. Okay. Oh yeah, that's right. That's why we kind of talked about it in class, but not really. So the exact cause of it is unknown, but it's believed to be a complex interplay of genetic and environmental factors. Okay. So there's an aspect of it that is motor neuron degeneration, because it's characterized by selective degeneration of motor neurons. Motor neurons, those are moving neurons, in both the brain and the spinal cord, which will eventually lead to a loss of function. So muscles will be weak or even paralyzed. There's also an aspect of ALS that could be abnormal proteins accumulating in those neurons, which disrupt cellular function. And if those cells start to not work, they start to kind of die because they're not working. They're not able to keep themselves around. Oxidative stress. So ALS is associated with that increased oxidative stress, which will damage motor neurons. Mitochondria dysfunction. If they're not working, then the cells will eventually die because their energy production goes down. And then immune system, which if it decides to attack them, they're going to die. Pretty rough. So they talk about a little bit of that here, where it's an upper motor neuron problem or lower motor neurons. I mean, both of them. Upper level motor neurons in the brain and brainstem, and lower level in the spinal cord and lumbar region, right? So you have the brain and the brainstem right here. Those are your upper level, and then the spinal cord that comes down here and ends with the lumbar region, right? It kind of spreads out. Those are going to be our lower motor neurons. In the brain and brainstem, the manifestations of motor neuron problems will be like spasticity, because it's like your muscles will still move, but the actual sending of the neuron, like the neuron sending is damaged, so it's kind of spastic, with a little bit of weakness. With lower motor neuron problems, you can't move. You have atrophy and like weakness that is practically paralysis eventually, where when those motor neurons are not working / even dying, you will eventually become paralyzed, basically. Variations based on limb onset, like so 70% of people start with limb weakness. Swallowing and speech ability definitely decreases. And then as the disease just gets worse, I mean, eventually you do lose total lower motor neuron use and / or upper motor neuron use. And the problem with ALS is that it is usually a fatal disease, simply because if your upper motor neurons are destroyed, you eventually are unable to breathe on your own. Like, eventually it will kill you because you will not breathe. It's very, very sad. ALS is a very, very devastating disease, because it will eventually, and there's a lot of work being done to, to increase the efficacy of treatment. But truthfully, it is the definition of terminal. It will take you out. And here's just a bit of a difference between the 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 onset here. Um, Things that, these are two very famous individuals, and the reason why it's called Lou Gehrig's disease is because of the baseball player Lou Gehrig. And where, it starts with some weakness, and it starts with maybe if it's upper, you maybe are a little bit, you kind of have these spastic movements, you feel weak, all that stuff, and eventually it does just progress. Yeah, we talked about that stuff. So onset usually older, 50 to 65, more likely in males. Early muscle weakness, twitching, cramping. So the twitching specificity coming from the upper motor level neurons, and then muscle weakness from both. Let's be real. And then in late phases, you're having trouble swallowing, having trouble breathing. You'll have cramps, stiffness, shortness of breath, insomnia, fasciculation, which is muscles twitching on their own. Kind of strangely regulated emotions, anxiety, fatigue, pain. So risk factors for getting ALS can be smoking, having a head injury, chemical exposure, and then one very interesting risk factor is diets high in MSG. So one of the theories regarding ALS, is that monosodium glutamate and / glutamate in general is a factor in the death of the neurons. Okay? It can kind of cause a bit of excitement in the nerves where they're overstimulated, and it's like you're I don't know, getting them high, resulting in cell damage and potentially cell death. Just something to think about. So, yeah. Oh, here are the theories right here. Glutamate cytotoxicity can be toxic if they are not able to get it out. Get excess calcium and excess neuron firing, which causes damage. Something that people can potentially get, and this is working. There's riluzole, which works on glutamate theory, which tries to help get rid of the glutamate so that, the progression is slowed. Abnormal mitochondria, we talked about how abnormal ATP production causes abnormal calcium levels, which causes, of course, death of the neuron. They have alexisome, which is still trying to be tested. Impaired axon structure and transport, energy depletion and toxic buildup, where the axons they are not great, so they don't work very well, and they eventually end up dying. Free radicals accumulate and kill cells. It takes 13 to 18 months for diagnosis, from onset of symptoms. There's not one diagnostic test, it's just excluding the other ones. Fasciculation, which, let's look it up. Oh, go away. I don't want to see you. All right. You see that? He's not doing that, by the way. Those are his muscles kind of doing their own thing in there. Little waves under the skin. And the way that this can kind of show, let's look at it on the tongue. Check it out. Look at that. That's crazy. He's not doing that, by the way. Crazy. MRI eliminating, they're looking for plaques or tumors. You would get plaques in MS. There's no tumors. They're looking for that tumor that might be seen in MG. They're looking for that thyroid tumor. If that's not there, then they're well, it's not those ones. Labs to eliminate, so they're looking for sedimentation rate. They're looking for any sign of inflammation. They're looking for thyroid function tests, remember, for that's any sort of thyroid issue. Electrophoresis, serum calcium, phosphorus levels, heavy metal screening. Progressive neuromuscular disorder that leads to loss of motor control. And it's basically just in maintaining quality of life, slowing progression as much as possible. Yeah. So they have the riluzole, which is focusing on the glutamate theory. Nudexa, let's look up that one. Nudexa. MOA. Modulating brain signals that essentially helps the spasms and helps spasms and the strain and emotional regulation basically. Adaravone, what's that one? Oh, helps to so those Adaravone works on the free radicals theory to help reduce oxidative stress, and then Relivero. Reducing neuronal death. So we have here riluzole, which works on getting rid of gluconate. Nudexa, which just helps to relieve those spasms and kind of regulate the emotions a little bit. Adaravone, which works to eliminate free radicals, and Relivero, which helps to slow the neuronal death. So all those different theories being evident in the drugs being used. So they may require a PEG tube as they lose ability to eat and drink. Vitamin E, and then creatine, which can both reduce glutamate toxicity. Purity extract, Pure PTE can slow progression as well. And that's it. A little bit. Well, I mean, it has been probably an hour and a half, so I was gonna say a little shorter than usual. No, it isn't. But yeah, that's it. So that's lupus and ALS. Yeehaw.